Welcome everyone, and thank you for joining the first AAH three-part series on COVID-19. I'm Jody Keelsealy, your facilitator for the day, and today the topic is Design Considerations, COVID-19 Preparedness and Infection Management. Today you'll receive a half HSW credit, and Lauren will be able to report for you. Unless you're calling in via phone, then you may need to touch base with Lauren because she doesn't know the phone number and who it's corresponding with if it's not logged in through the system. At the end of our presentation today, we will also have Q&A, or you will type questions into the chat area. Today, our presenters are Sam Burnett, who is a licensed architect and senior designer at ESA. He has led healthcare designs on meaningful US and international projects with his firm for over 30 years. Sam has developed research and educational initiatives and authored articles on reducing infections in healthcare settings, including the current COVID-19 challenges. Our second speaker is Gerald Versluis, who is a professional engineer with over 30 years of design experience in high performance and sustainable healthcare projects throughout the US. Gerald is also a technical writer, editor, and enjoys presenting engineering topics for conferences and healthcare groups. Recently, I heard someone say, never let a good crisis go to waste. So today we are here to learn and hopefully take away something useful, and I'm certainly sure that you will. So with no further ado, Sam, take it away.
Thank you, Jody, and thank you to our audience for taking part of your day today to learn the first of a three-part series that the local AIA chapter is sponsoring about the whole COVID topic. The first part, we're going to focus on the infection management of COVID-19 and how we as designers and mechanical engineers can do our part to help our owners of healthcare facilities be successful and hopefully more successful than they were the first time this hit, when we were all, as a design and a healthcare community, caught flat-footed with this sudden wave of a highly infectious pandemic that hit our healthcare facilities. We're going to show some specific examples of how you can provide useful design interventions, both architecturally and mechanically. And we're going to also talk about a general overview of healthcare-associated infections and some pretty staggering statistics before the COVID pandemic was even realized. This chart was recently updated from the CDC, and I just want you to focus on the bottom graph for this standpoint. These numbers are growing daily, obviously. It's a running tab, but if you'll notice the chart at the bottom, you're seeing the swing up and down. And the takeaway from this is the entire population is still handling this with very mixed responses. As a country, we're not taking it seriously and doing our part in the social distancing and protecting each other from those who are infected. To really be effective, this is not just about design. It's a team effort, and it starts with education. It starts with education of the employees, the patients, and the general public to understand what this is and what it isn't, and how easily it is spread, and really instilling everyone to do their part in keeping it at bay. It takes your infection control teams with the healthcare facilities to bring their best game, be actively engaged in the operational sides and processes within the healthcare facilities. The owners within the funding decision-making capacity need to be also informed and really champions of spending money in the right places with a good ROI in managing this. And a lot of money was spent in the wrong places this last time, building thousands of rooms off-site that weren't even used. And we're going to talk about specifically some good interventions within the healthcare setting shortly. Your EBS teams, of course, your cleaning teams, and your end users all have to be part of that. The design interventions, we're now going to talk about some of those after a little bit of education on the whole HAI history. HAIs, originally known as hospital-acquired infections, really expand beyond hospitals. It's healthcare settings in general. A CDC report done in 2014, a long time prior to COVID being an issue, identified 722,000 patients the year of this study, acquired an infection in a healthcare setting. 75,000 deaths from HAIs. That's a staggering number. That's 8 to 9 per hour. So that means during our time today, this short half hour, 4 to 5 people are going to die during this presentation, not even counting the COVID cases. That's equivalent to an Airbus A300 jetliner going down fully loaded with 200 passengers and crew every day. And that would make the news. HAIs did not make the news one at a time, but COVID is making the news, and it's really raised the awareness of HAIs and infections in healthcare facilities. The cost is staggering, and it will be a long time before we know the collective cost of COVID within our healthcare settings and what cases could have been prevented. That's a question we may never answer, but today we're going to talk about how we can do our part to help manage that. Again, healthcare settings are not just hospitals. Anyone who's following the news knows some of the worst cases are happening at senior living and nursing facilities where you have a captive audience and a very frail senior population. But this pandemic can be easily spread in any public setting, particularly healthcare, to at the top, as well as medical office and outpatient facilities, and certainly high population, high touch areas like physical therapy and rehab departments. So let's start at the tracking of the very first point that a prospective positive patient is going to present at a hospital where they're showing symptoms and maybe feel like they're sick enough to be admitted. Thankfully, there's a lot of testing centers that are not on hospital campuses, so someone who just simply wants to test really doesn't even need to be at the hospital. But once they appear at the hospital, the more proactive facilities have done a great job keeping them out of the facility until the testing is done, completed, and substantiated before they're even entered into the facility. Most facilities are not equipped to handle the volume that's coming in their front door or their ED at this time. In days of the past, prior to COVID, this is what a typical nurse station in an emergency department looked like on the left side. And they're very busy. There's a lot of visiting staff and EMS, police, chaplains, and other clinical visitors coming and going to these nurse stations. This nurse station in that view, I think, is a thing of the past with what we're having to do now to protect staff from each other, patients, and the general public. So if you look on the right, this is a very typical situation now in an inpatient setting, probably an ICU room, where the protective gear to protect staff from other patients and protect themselves from the infected patients is a very important part of this trend. The shot on the left was taken before COVID was even an event, and these glass panels were added for acoustical purposes, just to help contain the chatter within that nurse station or reception desk. As it turns out, they've really become very effective and useful as an additional shield just from the day-to-day traffic and vocal interactions between staff and visitors. For those facilities that didn't have that, very low-cost retrofits have been done. This is just a reception desk with probably a $30 plexiglass shield to provide some additional barrier between the vocal interaction between the general public and other staff and those workers who are our frontline people that we have to take care of. This is a very telling study, and there's a very wide range of opinions about the effectiveness of masks. We don't know where the most prevalent cases are being spread from person to person or aerial or surface contact. What we do know is it is highly contagious, and until we know otherwise, the use of masks have been an adopted measure as additional protection between the person-to-person contact. And the statistic on the far right really tells that. And this is a study. This is not opinion. So let's take the patient deeper into the hospital. They've been tested. They've been properly tested and screened. They've tested positive. They're too sick to stay at home. They need medical help. What our hospitals need to do and what as designers we need to do is look at every facility, whether it's new or on the boards, and think about a proper way to isolate those patients in a section of the facility. A lot of the hospitals tried the off-site experiment, and there was some limited success in the more urban populations, but the day-to-day suburban or county hospital cannot simply afford to staff and manage off-site facilities. So within the facility, what we need to help our clients understand is manage that patient transport to as little public space as possible, preferably a direct admission from the door they enter, whether it be the ED or a designated interim use as a designated COVID or pandemic entry point. The orange patient unit above shows the stacking of a 24-bed unit that was designed for direct ED admissions, not COVID admissions, but as it turns out, that was ideal for those direct admissions to those patients, which keeps them away from the other bed units and surgery and the other revenue producing areas of the hospital. Let's take it deeper into a patient room setting. And we talked about ROI a minute ago. When some interventions will require more money, this particular example doesn't require more money. It's just simply locating the sink and hand wash station and supplies very visually and physically prevalent to the clinical staff and visitors to a patient room or a patient treatment room. You literally have to walk past that sink to get to the patient, which encourages good hand hygiene. Further detailed examples of the dozens and dozens I wish we had time to show. I'm going to pick 3 for this presentation. The one on the left is a good graphic that emphasizes, think about your interior design being very cleanable surfaces, very void of a lot of cracks and crevices and ledges and all the nice details that make the architectural magazines, but make it extremely difficult for your housekeeping crews to clean. The shot in the middle shows a simple way to offset water at a hand wash station from the sink drain itself, essentially eliminating the splatter from that diffused water back up onto the person washing their hands, which you know would be a very negative event if that were happening. And lastly, if you take away one thing from the architectural part of this presentation, just stop using public drinking fountains. Those points, even before COVID, were highly contagious points of social interaction. And so the advent of the hydration station has gone a long way in helping toward reducing HAIs and now the COVID interventions that we're talking about today, because of the vertical water source that's not dribbling from people leaning over the typical drinking fountain. We can't talk about COVID without the importance of personal protection equipment that we call PPE. And every facility who we talked with got caught very short in having ample supplies because of the implied one-time usage for a lot of this disposable gear. It was a nationwide supply chain problem and a tremendous lesson that was gained by not letting that happen again. As designers, we need to do our part in providing proper storage for this equipment and properly locating it so that it's readily available at the points of care within the healthcare facilities. I'm showing the cleaning slide not because it's a design issue, but because to emphasize the point about joints and cracks and crevices in your interiors and in your furnishings. These cleaning processes, such as the fogging agent that's a hydrogen peroxide or a similar non-toxic agent, is only as good as the surfaces that it can get to. And if we have a lot of these finishes with joints and crevices and furniture with a lot of seams and piping and all those added details, these cleaning products can't reach those surfaces. And that's where some of these agents harbor themselves. An alternative to the fogging agents are UV light, which has been around for quite some time, and it gets more advanced with each new generation of it. Again, that lighting is only as effective as the surfaces that it can reach and contact during that sterilization process. I'd now like to turn it over to Gerald, who's going to show some very useful interventions and a brief education on mechanical design aspects in dealing with this topic.
Gerald?
I'm unable to share my screen right now. Sam, can you just advance it for me?
Yeah, we'll run through it for you.
All right. Hi, I'm Gerald Verslis, electrical engineer, and worked in healthcare for quite a while. This presentation isn't my opinion. I'm basically dealing data and facts, and everything I'll present today will be from CDC guidelines, ASHRAE publications, or case studies from UNMC and Northwell Hospital that were recently published. So what you have on the screen is, a lot of it's obvious. You've heard it a lot in the news. The virus spreads within droplets, the cough, sneeze, laughing, spitting, whatever, to a person within, say, 6 feet. But what you might not realize, a little more research is showing, is that as the droplet starts to dehydrate, the nuclei will float even further. It gets more buoyant within the air, and if it's in a HVAC stream, can go as far as 30 feet. So there's a lot more research to be on that, but we'll always keep that in mind as we go forward. So where we started in 2020. Where we started in 2020, the CDC said, when you got a COVID patient, what you need to do is put them in an airborne isolation room. That seemed kind of apparent. It's airborne infection, put them in an airborne isolation room. Then their second step was to go ahead and build additional airborne isolation rooms. And again, seemed like an obvious solution. And so as engineers, we started building isolation rooms. And we came up with, advanced slide. And we came up with a bunch of ways to, develop isolation rooms. We could, mount equipment outside, mount equipment inside, build vestibules, and give you basically an interim isolation room. Unfortunately, as time went on, from February, rolled into March, rolled into April, we realized that this wasn't an effective solution. What ended up happening was that negative pressure alone was not keeping the virus from spreading throughout the facility. Even, we would have an infected patient in an isolation room, and that virus basically would walk out the door, the isolation room door, with the caregiver. And there's documented cases of that. Why did this happen? A lot of it happened because the isolation rooms were substandard, or they didn't have a proper vestibule anteroom. So there's been an updated analysis in the response to COVID. Realized that when we design isolation rooms for a hospital, as dictated by our guidelines, that's for an airborne bacterial infectious disease like tuberculosis, anthrax, Legionella. These are living microbes, and they can live a long time. And so that justifies the ones through HVAC design. COVID-19 is an airborne virus. So it's like measles, flu, even like Ebola. Ebola is a virus. And it's like a zombie floating around, and it just wants to make living cells like itself. It's not really alive. And its half-life is much, much shorter. It's only about an hour floating around in the air. It cannot survive a modern HVAC system. So COVID, learning about that, CDC learning about that, updated their COVID intervention. They published it originally in 2019. They updated it. They said, what we recommend is putting patients in a regular examination or patient room with the door closed. There's some other modifications need to be made to the HVAC system, but in general, what you want to do is put them in a room that's huddled together with a bunch of other patients in a wing, and then have that HVAC system upgraded with a negative core. And that the CDC went on to say that COVID-19 patients that just test positive do not need to be in isolation rooms, negative pressure isolation rooms. That's really reserved for patients undergoing aerosol generating procedures, such as active tuberculosis. And what's really interesting is that, lastly, the UNMC study, University of Nebraska Medical Center, they documented it. Their University of Nebraska is kind of the tip of the spear for this type of care. They handled the Ebola outbreak in 2014. They accepted all the sick cruise ship people. You wondered where they went. That study was kind of pivotal. So where are we now? Basically, the original recommendations were to put COVID patients in isolation rooms. That's changed. It's only for certain procedures. The small scale surge capacity of building isolation rooms, additional isolation rooms with whatever parts you could throw together, that's not recommended anymore either. What is recommended is what used to be considered our worst case scenario of converting an entire wing into either a COVID ward or basically a negative patient ward. So what does that look like? That looks like this. Some of the features on the room would be that you'd try to cluster all the patients, and then you would have a single one-way flow of traffic through the wing. When you select the wing, you would want to pick a wing that doesn't have PTACs, which are those kind of hotel air conditioner type things, or fan coils for the rooms. You actually want to pick a wing that has a real HVAC supply system with either MERV 14 or 16 filtration on it. And then you want to negatively pressurize the core space. You want to make sure that there's enough services within the core space so that when your staff, your caregivers come in one end, say that top right end, and then they pass through into the patient care area, that they're not traipsing in and out. And it's very important to have a donning vestibule and a doffing vestibule. One of the things that failed in some of using the discrete isolation rooms was there really wasn't that path, and there wasn't adequate space to put things on, take things off without just spreading things around. So this is an example of how you would convert one portion of a wing and be able to use it. So in the news, and what you hear a lot about is ICU rooms. That would be for a standard care room. There's something different about ICUs, and for that matter, ORs. They're positive pressure rooms. That means if you have someone with COVID in them, the air is designed to disseminate the virus, the air within the patient room, out. It's a protective condition. So to increase the number of ICUs and for that matter, ORs, what you need to do is build a negative pressure vestibule outside it. And I've got a little hand drawing there that would show a way that you would configure it with a HEPA unit to negatively pressurize that vestibule. That way, any of the air that flows out of that patient room flows through that negative pressure machine, through the HEPA filter, and ideally UV light, before it goes out into the rest of the hospital. This is something on the next slide. You can see a physical example. It doesn't have the HEPA machine in it right now, but that's Kaiser Permanente Hospital. They proactively built these for outside these ICU rooms, and they can, when they drop the HEPA filters in there and then adequate doffing equipment in there, then they're ready to roll. So in short, I flew through a lot of stuff in a short period of time. It's almost more important to realize that the HVAC system can't fix a bad process. That's what we learned this spring, that just throwing someone in an isolation room doesn't solve all the problems. Process and flow and well thought out architectural design is really crucial to fighting this disease. Make sure that your facility that you're working with, anybody that you're working with in the healthcare system, if they don't have a plan, they do have that you can help them develop it. Pre-select a patient wing. Like I said, keep in mind what type of HVAC systems there. If possible, already upgrade the HVAC equipment. Some of that equipment may be available now, and then it may not be later. Buy the portable negative air machines, and stage them on site, readily accessible. And then start to establish locations for the partitions. You don't need to start building the vestibules, but realizing what it takes to build those partitions, because we've learned that a hospital can see a really quick uptake in the number of cases, and there's not a lot of time to think or run. And then lastly, make sure that your procedures are documented, and that will assure that when it's time to roll out that plan, there's not any doubt, there's not any second guessing.
Thank you, Gerald. Sam and Gerald, we all have time for some questions. We are coming up right on 3 o'clock, but everybody's willing to stay to address questions. And just a reminder to those who weren't on in the beginning, Lauren is capturing anyone who has signed in through the Zoom system, but if you've called in, you'll need to connect with Lauren to make sure she knows that you were on and connect you with the correct phone number that logged in. But any questions?
We stunned them into silence.
You can also put them into the chat box too, if that's easier. I have a question, Gerald, while we're waiting to see if anyone else. Maybe you can expand. I mean, it's so interesting that you mentioned that the virus isn't surviving in a modern HVAC. Can you maybe expand on what is considered modern versus non-modern?
Yeah, sure. By modern, I mean ducted supply return system that would have been built in the last 20 years, that it's going to have the final filtration that you would require for these spaces. It's going to have literally, hundreds and hundreds of feet of ductwork, because it's going to be either from a central air handler that's on the roof, down the hallway. And it's also there's a lot of things in between. I know people watch movies and they think those ducts are just big empty corridors up there, but when in fact they're like full of turning vanes and terminal units and heating coils, cooling coils, and the likelihood of it making that entire transition from return to supply is zero. It's just not going to survive that long through that many different conditions. And, that's not my opinion. That's, documented in a recent ASHRAE 170 article, and is really something that I think people are not aware of. We spent a lot of time in February blocking up returns and doing a lot of things that were really unnecessary.
Thanks, Gerald. Any other questions before we conclude? I'm just checking our chat box to see if anybody has submitted. No. Well, everyone, a little reminder that the next 2 sessions in the 3-part series, that you can accumulate as much as 1.5 HSW credits. On July 30th will be the next part of the series on rapid response. August 20th is planning for the, on the unpredictable. And Lauren is going to post the link in the chat box, and of course it'll be in the AIA newsletter. So stay tuned for more great information. Sam and Gerald, that was fantastic. Thank you so much. And I look forward to seeing everybody, hopefully in person someday in the not too distant future. Stay well, everybody.